for attending. We know you're busy. We know it's the holiday season. There's a lot you need to wrap up. But so thank you very much for your time for over this hour. We're going to get you out of here. A little bit left in the hour, but looking forward to this. Today, we're going to go through our webinar as Revenue Integrity Redefined. We're going to talk about our definition of, or MDaudit's definition of revenue integrity. But most importantly, we're going to go through our 2025 benchmarking report and try to send you home with a lot of critical intel, data, statistics, and insights that you can bring back to your billing compliance and revenue cycle programs to implement or even say, hey, am I seeing that trend? Is this something I need to worry about and take a look at it? And we're also going to go into what we're seeing ahead for 2026. So it's a packed agenda, and we're going to get through it all. I want to introduce myself first. My name is Dana Finnegan, Senior Director of Market Strategy at MDaudit. I've been at MDaudit for 9 years now, so really familiar with our platform and very familiar with the billing compliance and revenue cycle ecosystem. I'm really happy to be with you today. Just a couple of housekeeping items. You will definitely get the deck that we're using today. You'll also get the recording of today's session. You'll be able to get a comprehensive copy of our 2025 benchmarking report as well. There'll be a QR code in this deck that you can scan to get that report. You can visit our website as well to get that report. It's definitely something you're going to want to take home with you. We're also going to be asking you to take a short survey at the end just to tell us how we did. Any thoughts you may have on things you may want us to present in the future as we do monthly webinars. And I would also just say that, one of our goals too is to send you home with at least a handful of nuggets of information that you can implement into your life, trends, insights, etc., that can help you see what's going on in our billing compliance and revenue cycle ecosystem. And if there's any questions along the way, please enter them in the questions at the Q&A section, and we'll try to save time for those at the end. So let's jump into this. Who are we? Well, MDaudit is sponsoring this webinar. And a little bit about MDaudit for those of you that don't know, MDaudit is we, first of all, we recently acquired Streamline Health in August of this year. And together, we've come together to form a really powerful partnership to offer what we call revenue integrity assurance. And we'll talk about what that means in a moment. But together, that partnership serves over 200 customers with a nationwide footprint. Not only that, but we've had well over 30 years of experience in the billing compliance, revenue cycle, and coding HIM spaces. So everything we're going to present to you today comes from years of working alongside folks like yourself in the trenches, in exposing a lot of what we're seeing to you. Little bit more about what we do. And I'm bringing this up not because I'm, trying to push a platform on you or sell a platform to you, but this benchmarking report comes from all of the data that we're able to squeeze out of our MDaudit community. So really what we do at the end of the day is whether you're in the front, middle, or back end of the revenue cycle continuum, we have solutions to support you. We are able to ensure that you're billing compliantly, but almost as important, or more importantly, that you're maximizing revenues and you have healthy cash flows, particularly in this time where the healthcare landscape is so highly regulated and there's such intense payer scrutiny. And how do we make sure that you're billing compliantly and in maximizing revenues? Is we have solutions for folks on, let's say, both sides of the fence. Those folks that are heads down in compliance, making sure things are being billed to the highest level of accuracy and integrity, a tough job. We have risk solutions to help you mitigate any type of compliance risk. And on the other side, there's a host of revenue solutions for those folks that really have those blinders on and are trying to maximize revenues and net revenue generation. But enough with that, just wanted to kind of let you know what we do, what we're all about. But let's jump into our why we're here, our benchmarking report. Now, Many of you in the MD audit community are very aware of this benchmarking report because we offer it every year, we present it every year. But for those that are not as familiar with the report, we want to first just talk about how it's compiled. We're not going to go into too much detail, but this is not a survey. So when I talked about having 30 years of experience in the ecosystem, 200 clients across the country, that's going to represent almost 5,000 facilities using the MD Audit platform, $200 billion in uh, denials that are uh, analyzed on an annual basis, close to a couple of million of claims audited on our platform. So again, not a survey where we kind of cherry pick from certain clients and facilities. This is representing our entire MD audit community and what we're seeing when it comes to what's being scrutinized by payers, what's being denied, what's being audited. We're going to get into all those details now, but it's a very comprehensive analysis of what we're seeing across our client base. So the first place I want to start is with revenue integrity assurance, but how MD Audit really defines revenue integrity. There's many different definitions out there, but what you're seeing here is a slide that I've really presented many times over the years. It hasn't changed much, except for one little piece of it. So what we consider revenue integrity is that everybody along that revenue cycle continuum, whether you're in revenue cycle, billing compliance, coding and HIM, if you're on the clinical side of things, patient experience, patient financial services, that everybody is really sitting around the same table, even if that's a virtual table, really sharing ideas and breaking down silos. So I had mentioned that I've used this slide over the years. What's changed is when I would have presented this maybe 2 to 3 years ago, many of these departments were highly siloed. They weren't really sitting at that table together. What's great is we're seeing all these folks really start to develop programs where they all do sit at that table and share insights. So we're seeing the breaking down of silos, which is great because these folks from different constituencies are going in and kind of forming a united front, is what we call it, against that payer scrutiny in regulation. The one thing that is still a little hasn't been completely adopted yet is what's at the very middle of that table, which is billing and payments data. We see people coming to the table and breaking down silos, but we also see them coming with their own data. Meaning, when we talk about claims being sent out, denials, payer audits, when you're auditing physicians, who's passing, who's failing, same with coders. Everybody's kind of bringing their own disparate data that's saying different things. That kind of holds you back from creating a united front against payers. So at the end of the day, great that you're coming together, but make sure you adopt a technology that allows you to share data across these different constituencies. There is technology out there that can ingest your billing data, your denial data, your audit data, internal audit data, your payer audit data, aggregate it and make it consumable for all of you so it's reconciled and you're all working from the same data. And we're going to talk about later on the power of community in the sharing of data and how important that is to being financially sustainable. But just keep that in mind. Make sure you're coming to the table together, putting egos aside, and sharing data. Because at that point, you can do anything when you're working together. And we'll talk about how technology can help you get to that data so you're all looking at the same data. So I want to go into first some of the 2025 key trends that we're seeing. Now, when I first put this slide together, I thought about changing it because I thought, well, when I present these main 2025 key trends that I may be kind of a little bit of a downer or raining on your parade, but it's real. And I think we all understand that these are things that aren't going to jump out as a surprise, but it always is good to know what your peers are going through. So the first one is denials are certainly on the rise. And I should mention, we're gonna dive into each one of these four as we go along today's session, so I'm not going to dive in right now, but denials are certainly on the rise. Payers are doubling down on their denials. We're even seeing a case where those authorization and pre-cert denials, which were always the number one reason for denial, are actually not the number one reason. We're seeing other reasons kind of surpassing those front of the revenue cycle denials. Payer audits are certainly increasing by both the government and commercial payers. Those attempts to do clawbacks are just going through the roof. Whether those are prepay clawbacks or post-pay clawbacks, where they're requesting those medical records. We know why they're doing it. They want to come back and take some cash that you've earned in most cases. So denials on the rise, payer audits increasing. And on that right-hand side, number four, this was kind of the newest trend that is certainly concerning, that outpatient coding seems to be worsening. We're going to talk about what that means, but with AI and autonomous coding in the ability to really find really qualified coding professionals, it's certainly an issue within our community. But again, technology is going to help you recognize some positive outcomes. So that's why we go to number three. As I said, one, two, and four may paint kind of a not so happy picture, but technology can be implemented to really unlock some positive outcomes. And we are seeing that in the MDaudit community. And we're going to share that with those that are not in our community to help you implement some of these technologies that can help you really have better financial outcomes. So those are some of the top trends that we're going to dive into in more detail in a moment. Um, Before we jump into the 2025 data, we want to talk about year over year. Now, this slide may be a little hard to kind of visualize or read it. I wanted to get everything in here, but there's really four quadrants that we're looking at here. And we haven't just gone from 2024 to 2025. We've taken a 3-year trajectory here. And what we're seeing over those 3 years is, again, coding related denials going up and up and up over that 3-year period, really surpassing those pre-certs and authorizations and eligibility related denials that we're so used to being the number one reason for denial. The other one that I think is really interesting here is denials going up for information needed, those RFI denials and med necessity. At the end of the day, I think we know what's going on there. Payers may not have as many reasons to deny us for eligibility and other things, timely filing, whatever it may be. So they're doubling down on saying, well, this was coded right, but I need more information supporting the level of services that you're sending to me. Even if that's spot on coded correctly and supported by the documentation, you're being burdened with having to send the documentation to support that med necessity and the information to really back that up, which again, if you're denied for that reason, is going to really have a lot of rework and a lot of effort to send out that documentation, and is going to, take you much, much longer to receive that reimbursement that was due as soon as you really submitted that claim. So they're really doubling down on that RFI and med necessity related denials as well, on top of the coding related category of denials. I don't think it's a surprise to any of us that the denied amount for Medicare Advantage plans is going through the roof as well. We're going to talk about how those Medicare Advantage plans are being incredibly scrutinized by CMS and OIG, and how that's going to trickle down to you, those that are providing care. Because those Medicare Advantage plans receive so many overpayments based on some of what they were submitting to CMS, you're going to be caught in the crosshairs of that scrutiny. And we're going to, again, dive into all of these. And finally, I think the steepest trajectory you see over the 3 years is the external payer audits that are showing up from RACS, MACS, TPE, UPIC, SMRC, that whole alphabet soup that's kind of sending you these medical record requests, again, because they're wanting to possibly do some clawback. So you have to not only be ready to have the bandwidth to fight denials, but those payer audits that are coming at your back door as well. Those are some of the bigger trends we see, not just over 2024 and 2025, but for the last 3 years and more. And I'm sure most of you are seeing the same things here. One thing that I forgot to mention at the beginning was Some of what you're seeing today is macro level. And macro level is great, but if you do access the report, which you will be able to, you're going to see the all of the really granular trends that support these macro trends. So you'll be able to go in and see what DRGs are being denied most, what CPTs, what payers are sending out the most external payer audits, and why. What are they looking at and looking for? So again, macro trends here, but you'll absolutely be getting the gory detail from the comprehensive report. So we're going to break this down into two sections. There's going to be a billing compliance insights, because again, there's many of you that are working to mitigate that risk on a daily basis. But then we're going to jump into some of the revenue cycle insights from the report for those that are really responsible for generating that net revenue. So let's start off with billing compliance. So the first thing we have here is risk-based audits increasing by 25%. And again, this report is based off of 2024 to 2025. So risk-based audits in 2024 had gone up, I think, over 100%. So it was huge, but we're still seeing those risk-based audits going up even incrementally in 2025 by 25%. Really, what this is at the end of the day is it's not feasible anymore with the bandwidth that your teams have to go in and say whether I have 100 providers or 1,000 providers or 10,000 to see each one of them once a year, take a sample size of 10 or 20 of their claims, and then go and educate them. It's not feasible. You don't have the bandwidth. So you really have to take a risk-based approach to really figure out that 20% of the provider population that may be causing 90 to 100% of those overpayments and underpayments and other issues, documentation deficiencies, and so on. The only way to be able to do that is through risk-based audits. And when I say a risk-based audit, at the end of the day, it's synonymous with continuous risk monitoring. Technology like MDaudit, and again, I'm not here to push it on you, but there is technology out there that can literally watch every claim that you submit and then bump that up against what we call benchmarks. See how your provider's E&M leveling patterns and procedure utilization compares to what CMS considers normal for that specialty, for that part of the country. Same thing with DRGs, with vents over 96 hours. How many of those are you doing compared to others just like you? So benchmarking can help you compare your internal billing patterns to not only CMS, but within like the MDaudit community, others in the MDaudit community just like you. At the end of the day, you want to make sure that you have comparative data. You can't just be operating on what you're seeing in your own organization. You need to have comparative data wherever you can find that, and there's a lot of vendors out there that can offer that, like MDaudit, to see how you're comparing. That allows you to, again, wipe out 80% of the providers that are doing the right things, and really concentrate on your outliers for overcoding and undercoding, even things that can identify who your newly billing providers are to the organization, because you want to audit them immediately as well. So make sure that you're starting to move towards a more risk-based approach. No more of the days of seeing each provider once a year, just not ability to keep up with that. Kind of part and parcel with risk-based audits, is prospective or pre-bill audits. Those also jumped by 30% in the MDaudit community. Now, it's not as easy as just saying, okay, I'm going to put claims on hold. You need to work out with those along the revenue cycle continuum, what is an acceptable point of time to hold claims. Now, we get a lot of folks originally that would say, I don't like to hold claims. I got to get them out the door. We've got to get cash in it. We totally understand that. But just holding up a claim, even for 24 hours, in order to do a pre-bill audit where coder and auditor can come together and have dialogue to say, what do we need to do to make this go out with the highest level of accuracy and integrity, even querying providers to shore up that documentation. Even that 24-hour time span is going to allow you to significantly increase, I should say decrease your days in accounts receivable, and really recognize much higher first pass pay rates, and really lower denial rate. So again, you need to not only adopt a risk-based approach through continuous risk monitoring, a data-driven approach through benchmarking and analytics and AI, but also have room in there for pre-bill audits. We're not saying you can't do retrospective audits. Most in the MD audit community have a really nice blend of both, but you've got to start moving towards retrospective. Do your retrospective, but go to risk-based and pre-bill audits. And many of you are from Epic shops. It's real easy to put those claims in a hold mechanism, a work queue, so then vendors can bring them in and put them in front of you and allow you to have that dialogue and really fix those claims before they go out the door. So, and that's not just Epic, that's for anyone that's producing ANSI standard claims. They can be put on a hold and you can do the right things to send them out and recognize those first pass pay rates. And that's exactly what is happening in the MD audit community. HCC audits increased 102%. We touched a little bit upon that earlier with the macro trends, but I don't think any of us didn't read that Wall Street Journal article where they went into a lot of deep detail about how Medicare Advantage plans recognize over $50 billion in overpayments when they were submitting diagnosis codes to CMS. So because of that, those Medicare Advantage plans are going to be under intense scrutiny. And again, as I said, that's going to trickle down to you. You're going to be under that intense scrutiny when you're billing out these HCCs. So again, it's not feasible to just rely on human intuition to say, I think we should worry about these HCC categories. And I'll just pull a small sample size every once in a while. Again, you need to take a risk-based approach when trying to decide, where I may be overutilizing or underutilizing HCCs. So that's another thing technology can help you do. It can compare your HCC utilization to others just like you, organizations of similar size and constitution and payer mix and regionality and state, and say, you look like you're really overutilizing this HCC category, and allow you to immediately back into those claims and do audits of those. And again, you have to be auditing your HCCs, again, take a risk-based approach through analytics. And then we talked about prospective audits. Nothing wrong with, doing some pre-bill audits of your HCCs as well, but take an approach of both grabbing random samples and a risk-based approach based on, again, AI, benchmarking, analytics. But at the end of the day, do more risk-based audits, do more pre-bill audits, and bake into that auditing your HCCs as well. If you do this, you are going to see a lot less payer audits coming to your back door. Want to talk about payer audits. We're going to spend a little bit of time on this slide, but I don't want to spend too much time. Actually, it looks like we're almost at the half hour. But payer audits coming from Medicare, Medicaid, commercials. We saw an increase not only in the number of cases being requested, but the at-risk amounts as well. So payers are doubling down on that. It went up 30% year over year. Now, one of the things that people often ask is, well, what can technology do to help me fight these payer audits? A lot of times you get that ADR letter, the additional documentation request, it just goes somewhere and it gets lost. Or you may get it and not start working on it till a week later because there's just a lack of bandwidth and a lot going on. So I want many of you will be familiar with these terms, some people won't, but a good technology can offer you things like EMDR, something MDaudit has. EMDR, if set up correctly, whenever you receive an ADR from Medicare or one of their contractors, EMDR can automatically receive that for you and tell you that you've received it so you can start working on that ADR right away. So that's EMDR. Another thing a good technology should have is ESMD. That allows you that once you gather all those medical records, ESMD is the electronic submission of medical documentation that allows you to send it back directly and electronically to those requesters. So if you have EMDR on the front end and ESMD, think of it on the back end, to not only receive but send it back immediately, Right there, you're putting yourself in the driver's seat to make sure you're responding on time with those medical records. Now, another thing a good technology would offer, along with EMDR and ESMD, is automated task management. What that does at the end of the day is it allows it as soon as you receive that ADR, technology can use AI to read that ADR and then throw tasks at the persons in departments responsible for doing them. So if you think about it, when an ADR comes in, it's not one person handling it. Everybody's involved. There's billing compliance, there's revenue cycle, there's CDI, there's coding. Everybody is a stakeholder in that process. And if everybody's working in disparate systems and behind silos, you're never going to retain revenue. You're going to be refunding most of it. So write this down. Look for a vendor that can offer you EMDR, ESMD, and automated task management. We've seen in the MD audit community when those technologies are applied, I should say employed, there's a 98% retainment of at-risk dollars. The refunds are minimal. And what should wrap itself around that technology too is we talk about AI. MDaudit's AI has the ability to watch your payer audits, what's coming in, what you're sending back, looking at those determination letters and reading it, and providing you a reporting suite to understand who's sending you these letters, why are they sending them, why are they denying them, how are you doing with appeals, all of that information. More importantly, an easy button to see at any point in time, what am I retaining versus what am I refunding, and being able to fix the failure points in the process of why those refunds are taking place. So at the end of the day, all I can say is payer audits are going through the roof. It's going to continue. And you really need to adopt a technology that has some of the things that I've talked about. It will absolutely help you be more financially stable. Audit outcomes. I thought this was interesting. I could have just articulated it, but I thought it kind of painted a picture being on the screen. So the MD audit community that is employing a risk-based approach and prospective audits and has the technology to fight payer audits. We're still seeing when audits are done through all of those different ways, 25% of rendering providers failed professional audits. And 36% of coders failed on the hospital side, facility inpatient and outpatient failed audits. Now, that seems high when there's all of that technology, but if you think about it, what it's able to do and what we've seen, the positive side of this is when we've re-audited the providers and coders, we're seeing a significant decrease in failure rates already just a couple of months in when they've been re-audited. Why is that happening? Why was there a high failure rate and then such a drop in that rate? Well, any good technology should also be able to allow you to audit your providers and coders, but watch everything you're doing and produce boots on the ground educational packages. What we see as a failure point when auditing physicians, coders, anything you're auditing is a lot of the effort is just put towards pulling the sample size and getting through the audit. There's no reporting or very little reporting that is kind of, you can press the easy button, get to it. It's a lot of manual effort on your side. You're not going into those conversations with providers and coders equipped with what you need to have that healthy educational dialogue and corrective action plans. So just wanted you to see that this if you look at it in isolation, it seems like high failure rates. But the positive side of this, and I didn't put the statistics here because I have to kind of analyze them a little bit more and reconcile them, but already I'm seeing an incredibly positive downward trend of failure rates, almost in some of them into the single digits when the right reports are shared. Now, another thing that some of our MD audit community is doing is auditors are going in and having this healthy dialogue with the physicians, but we're also starting to create some packages where clinical department heads can meet with their providers, chief medical officers, or maybe the department head in anesthesia or orthopedics. we've really heard a lot from our MD audit community that when it's provider to provider, peer to peer, that education can even sink in faster and quicker. We're not downplaying the importance of an auditor going in there and doing it. We want the auditors to be there. Maybe the auditors can work in tandem with those clinical department heads, but employing that approach has significant positive outcomes. So something else you may want to think about is, can auditors and some of those department heads come together and have that dialogue with the physicians that need it and that are have opportunity for improvement. All right. This one here was something brand new to me that I saw. We really saw a huge increase this year was really clinical documentation audits. I'm not going to go into this too much, but we were very happy, very pleased to see in the MD audit community that not only was a lot of coding quality audits being done via risk-based approaches and pre-bill audits and so on, but that the technology was bringing together providers, coders, and CDI professionals. What we're able to do and what you should be doing as well is getting those people. I know it's easy, it's not the easiest thing because everybody's so busy, but when you put those people in the same room and show them this is what was in the documentation, this is what went out on the claim, and they can have that healthy dialogue. We're seeing not only more CDI audits being done, but a lot of improvement in documentation to improve net revenue generation. And even on the other side of the spectrum, showing where the documentation is not supporting the codes that are going out on the claims. Again, bringing together providers, coders, the CDI professionals in the same spaces is reaping huge benefits. But also wanted to show that we've seen a huge increase of just clinical documentation audits year over year, in addition to those coding quality audits that are going on. I think this is the last insight we have for billing compliance, but a lot of folks in past years and things I get asked a lot when we're meeting with clients is, what are the sizes of teams? Because everybody feels so small sometimes, very little bandwidth. So this is what we glean from our community. Now, when you're reading on the left-hand side there of the number of auditors for team size, one of the big things we're seeing now is really two different auditing teams working together, but having kind of different things under their purview. Really, at the end of the day, we're seeing the emergence of new auditing teams on the revenue cycle side as well. Now, of course, their kind of thing is to go in there and really concentrate on what's the root cause of underpayments. Why is that happening? Because we want to reap that. We want to do rebills. We want to kind of bring in that extra revenue that's owed to us, where compliance folks are really trying to concentrate on those overpayments to mitigate risk. But at the end of the day, this is what we see for team sizes. But we're also seeing no longer the model of just auditors on the billing compliance side looking at overpayments. We're seeing teams forming now on the revenue cycle compliance side, really taking a look at those underpayments. At the end of the day, though, you have to be looking at both sides of the coin to really be financially responsible. This was one last thing I would throw up before we get into the billing compliance. And this is also kind of a tease of what you would get in the comprehensive report. Everything I've talked about has a ton of gory detail that you can dive into. But payer audit scrutiny, what we were able to see on the outpatient side, the inpatient side, and pro fee side is these are the top codes in those places of service being scrutinized by payer audits, both government and commercial. I don't think we're really surprised on the inpatient side with sepsis, but we're seeing a ton of scrutiny for those cardiac valves, ECMOs, infectious and parasitic diseases, particularly with MCCs, and even the major small and large bowel procedures with MCC. So this will be great for you to take back and say, am I getting payer audits for these? You probably are. And if I'm not, let's start preparing for some of these to come in. Let me do some sampling of these different DRGs and CPTs and make sure they're being billed to the highest level of accuracy and integrity. And that we feel like we can stand behind that if audited by that alphabet soup we talked about before. But again, you'll get a copy of this. So now we want to kind of put a different hat on. Billing compliance, real tough job, doing everything they can to mitigate risk. to the organization. But let's jump into the revenue cycle side of the world. Those wearing the hats to maximize revenue. What are we seeing from that in our data? Well, this is not a surprise. I'm not here to say payers are the bad guy, that they have a job to do too. But what we're seeing, and this is year over year over year again, is that their response times to adjudicate claims are going up again. So you can see on the inpatient side, it's gone up 3 days. Their initial response to adjudicate your claims gone up 3 days. On the outpatient side, gone from 34 to 41. Professional, really big jump from 15 to 24. So I think the big thing about this is what we want to kind of tell you is in the MD audit community, where we see folks really fighting this and having really good outcomes is when they track this metric. This is something you should know and track all the time, weekly, monthly. How long is it taking them to respond? Now, 3 days on the inpatient side doesn't seem like a big increase, but when you're talking about the fact that they are taking longer to adjudicate and they may deny you for an RFI or additional documentation needed, it pushes out your payment exponentially. And you can't, with the reimbursement at stake for that, you can't push it out any more than a day. So track this metric, take a look at it, and most importantly, have a payer relations team or a team that is able to go to the table with payers and bring this into the negotiations. Your payers have a responsibility to respond in a certain amount of time. That's all documented. It's all within your contracts. Bring it there and don't be afraid to negotiate at the table. I'm not saying it's the only thing you bring to the table, but if you can bring, hey, payer, it's taking you longer to adjudicate, you're not holding up your end of the bargain. Oh, and by the way, you've denied these 100 claims, and we are following your policy. If you can bring a lot of that to the table, we are seeing really positive outcomes for folks that have their data together and bring it to the table with payers. Now, of course, if you're trying to go to the table with a huge national payer, you could get swatted down, but you could start off slow and go to some of your smaller regional payers, work up your repertoire, and then provide, once you kind of get confident with that, bring that into your bigger national payer negotiations. We're seeing people have really great outcomes when they have payer relations teams on top of this and are taking a data-driven approach. This is the one that I want to spend the most time with, but coding-related denials, up 26%. Last year, coding-related denials were up 126%. So even though you see 26%, it's a big number, but when you think of last year was 126, it's staggering. Now, there's many reasons for that, but a couple of them that I want to talk about today that we see all the time are a couple of things. Yes, we know it's really hard to retain and even hire your top-notch coding professionals. We know that it's kind of a pain for all of us. But the bigger trend here is autonomous coding. So in AI, we are 100% proponents of autonomous coding and AI, but at the same time, what we've seen as a failure point is folks employing that autonomous coding, but not having the governance and teams wrapped around it to watch the output. When you have AI and autonomous coding making coding decisions at scale, and within that AI, there could be erroneous reasoning and just I don't want to call it, but not accurate logic. There can be so much going out the door that could be really escalating those coding related denials. So at the end of the day, huge proponents. I hear really good things about Epic's SVC module, but at the same time, it has to be highly governed and tweaked along the way. You just can't let it operate at will. So at the end of the day, two things seems really simple, but always be having those corrective action plans and educational dialogue with your coders. And at the same time, when you're employing autonomous coding, have governance wrapped around it, have a team that's doing QA on it on a fairly regular basis, at least monthly, to make sure that things are being outputted appropriately. Now, one other thing I would say is payers, of course, as we know, are adopting all different types of AI to deny you more and double down on that. So you want to also create your AI and govern that AI, because if you're not employing it, you're just going to drown with those payer denials and payer audits. So again, we're supporting it, but keep an eye on it. Here's another one we talked about a little bit. Years ago, it was very common to just say the number one denial category was stuff taking place at the front end of the revenue cycle, eligibility, authorization, pre-certs, all of that. That's now, I mean, that's still an issue, but what's surpassed that now is we talked about coding related denials, but now the RFI and med necessity. I won't kill this with too much detail, but we saw this really being doubled down on by commercial payers and particularly also Medicare Advantage. So think about it. You're getting that claim in timely. It's absolutely coded to the highest level of accuracy and integrity, but you're still getting these RFI and medical necessity denials, particularly with things like uh, higher end ED codes, DRGs with fence over 96 hours. They're asking you to submit documentation to support those levels of service. So this is something you're going to have to come to expect on a regular basis. With the MDaudit platform, what folks are able to do is really just dive into these particular denial categories and drill down and say, these are the actual services by CPT, by DRG, maybe certain diagnosis codes that we know when we submit them, we are going to get a request for more information. So you'll get these denials, but you need to have technology allow you to drill down to root cause of the payers that are sending you these denials. It's going to be commercial and Medicare Advantage for the most part, but also what are the services that they're going to regularly ask me for this supporting documentation so you can be ready to go back with that documentation immediately. So just be aware that you've got your coding related denials, but this is another really, really big one to be prepared for. And again, technology can help you understand the services that are being scrutinized for RFI and med necessity. This is the same thing. Just wanted to mention that for Medicare Advantage requests and denials for RFI and med necessity, that has gone up 5 times from last year. Makes sense as we talked about Medicare Advantage plans being intensely scrutinized, and that is going to trickle down to you. Just wanted to also show, and again, I wanted this to be a little bit of a teaser because we don't want to just give you macro trends. You're going to be able to now see here on the professional side, the inpatient side and the outpatient side, some of the top coding related denials. One thing you'll see when you're able to take this and just have more time to look at it is there's some common threads here. Big issues with procedure and modifier combinations on all different chart types. That's a big one. Diagnosis related issues. And the one that is purely going to cross all of these chart types is where it says payer deems the information submitted does not support this level of service. So just, when you're submitting those level 5 EDs, those level 5 established patients, you are going to get some sort of very good chance you're going to get denial saying we don't feel you've supported this level of service, and then need to send in the supporting documentation. But I would say go home, take a look at these, take a look at your CARCs, take a look at your RARCs. I know you're going to be seeing the same thing. And again, if you're not able to get down to this level of detail with an easy button, make sure you call us, employ a technology that allows you to really be able to see root causes of your denials by provider, specialty, facility, location, payer. Again, with that easy button. The more time you spend trying to vet out why this is happening, you have less time for better appeals and getting back that reimbursement. Make sure you're not spending really any time trying to find that root cause. Technology can do that for you. This is the last thing that I have on the revenue cycle side. I kind of slapped this in at the last minute, but it's from Becker's. It came out the other day. It's been a long time since I've been on your side of the trenches. working in billing compliance and revenue integrity. I did it one time. But one thing that wasn't common at that time was that payers were starting to pen down coding policies. I was always used to reading their clinical policies and in just their regular adjudication policies, but now you can see up top, Cigna is launching a down coding policy. Well, it's already launched as of October 1st, where they're going to really just at will start down coding a lot of those. You can see 204s to 205s and so on. That's a national payer, but we also see at the bottom Blue Cross Blue Shield Massachusetts, a small, localized payer for Blue Cross, doing the same thing. So I think what we're doing here at MD Audit that's really helping folks, and you're going to want to do on your side as well if you're not part of our community, it is really have analytics and technology in place that can identify the accounts uh, that are being down coded. These are ones that I recently heard at a conference someone say, "Well, we're getting down coded on a regular basis for our established patients in our EDs visits, but we're also getting a lot of DRG downgrades." In what kind of I felt bad for this organization was they said we don't have the bandwidth to go after the pro fee down coding. We can only put our resources towards the facility side of things, the DRG downgrades, and that makes sense because there's a lot of money at stake. But we want you to be able to really go after all of these. And you can't with the bandwidth you have. So there is technology out there that can automatically identify where these down codes are taking place by account number and serve them up to you so you can start really working on them immediately and doing the things that you need to do to fight for that additional revenue that is supported in your medical records. So don't again, if you want, you can contact us, but make sure you're working with the technology that doesn't, you don't have a team going in and trying to find a needle in a haystack. That's what the payer wants. Employ technology that allows you to see these immediately and kind of fight that good fight. And again, if you start fighting that good fight and you get that reimbursement, that's something that if it continues, you're going to want your payer relations team to go in and say, look, we've done this over and over. You're paying us. Why are you, downcoding this? We have the appropriate documentation. But something that really jumped out at me was just the willy kind of nilly downcoding payers are doing, and you want to really be aware of it on both the national level and the regional level and state level. So we want to kind of end with 2026 predictions. So we're going to go through these and then we're going to see if there's time for questions. But this is pretty, I think, obvious to all of us, but there's certain things you can do to make your lives better. So denials are going to become more complex, but they're also going to become more preventable. They're going to become more complex because payers are going to continually adopt AI and other benchmarking and analytics to just deny you for any way that they possibly can. So at the end of the day, you want to adopt a pre-bill revenue integrity solution with predictive analytics to help you mitigate those denials. And at the end of the day, what that means is there's technology out there that can look at your pre-bill charges really right after the point of coding and bump that up against payer policy. It can be bumped up against NCCI, CCI edits, MUE edits, coding documentation, coding policies, and say, look, before this goes out the door, add this modifier or resequence these diagnosis codes. It's not only going to help you bill more compliantly, but it's going to help you optimize revenue. These solutions are going, I want to be honest, they're going to be different from your traditional scrubbers. We're not maligning scrubbers and saying they're doing good things. They're making sure that every field, loop, and segment in that 837 INP is populated with the right information and so on and so on. But make sure you're looking for those predictive analytics and pre-bill revenue integrity solutions that can bump your claims, your charges versus payer policy and the other things I talked about, because that is how you're going to be able to prevent denials. Scrubbers alone are not going to cut the mustard. Payer audits are going to escalate. Payers have now adopted, we're not only going to deny, but we're also going to try to do clawbacks. So those are going to always continue. And we already baked that out pretty far before. Make sure you have a technology that offers at the minimum EMDR ESMD, automated task management, and so on. Um, you got to have that in order to respond on time and get a leg up on payers that are going to continue to send these to you. Um, Technology will drive survival at first, but then it's going to lead to a competitive advantage. So it's just our way of saying that technology not only can be used to identify risk, but there's also powerful workflows that'll help you respond back in time to what the payers are looking for. That'll create not only operational efficiencies, but ability to overturn denials at mass. So again, if you're not using a technology, um, reach out to us or employ one. It's going to again first probably help you survive, but then lead to a competitive advantage. I think the most important one here is outpatient coding accuracy is going to be synonymous with financial performance, meaning good financial performance if that coding accuracy on the outpatient side is accurate. So it's what we talked about. Have governance around your autonomous coding. Ensure that you're meeting with your coders on a regular basis for education. Have those reports, those boots on the ground educational reports, so you can have healthy dialogue. Even have a healthy review and rebuttal process. We've seen on the MDaudit platform when there's an ability for auditors and coders to have real-time dialogue, it is significantly increasing first pass pay rates. But outpatient coding accuracy is key. That's where we see the payers, commercial, government, Medicare Advantage, really doubling down on coding related denials is on that outpatient side. And I think the last nugget here, and it may seem a little pie in the sky, but it's don't forget the importance of community. And I say that because everything we just talked about today was based on what we're seeing happening in the MD audit community. Not just the detail and the intel and the statistics, but the MD audit community shares data with each other, best practices, what they're seeing happening. So again, we want to talk about don't isolate yourself to just your healthcare system. Become part of a community, and that can be done through a vendor or however you choose, where you're able to share and say, this is what's happening to me. Is it happening to you? And if so, what are you doing to mitigate it and make it better? Break down those silos, not only internally, but for the other healthcare organizations out there of similar size, constitution, has having similar payer mixes. There's a huge amount of positivity that can come out of sharing that data within a community. Um, so, folks, that's what we wanted to go through today. Again, you can scan this QR code. You're also going to get this deck where you can scan the QR code, and you'll have not only the macro views that we talked about today, but you'll be able to dive into CPT codes, DRGs, diagnoses, all those things that are being scrutinized within the MD audit community, so you can bring that back and do some audits on your own, whether they be billing compliance audits or your revenue cycle audits. Um, what we have probably time for maybe one question. So I know Joy, you've been monitoring the chat. So let's take a question.
Sure, Dana, thanks. Great job. We do have a few questions. The first
Okay.
is, do you have any data showing the size of institutions to add into that the auditor's slide?
Do I have anything to add? Can you just repeat that question? I didn't get it right off the
Um,
bat, Joy. Yeah.
do you have any data showing the size of institution to add into that number of
Oh,
auditors?
yeah, certainly. That's something that's I don't have it off the top of my head, but we can certainly dive into our data. That would probably just take a few seconds to match up the size of the organizations with the team size. It's actually a great question, probably something we should have going forward. So I will take that back, and if the person is okay with us contacting them, I'll certainly add that in.
Perfect, thank you.
Yeah. Any
Next,
other, Joy? Yeah.
we do. Once you determine which codes payers will most likely request additional information for, do you recommend sending notes with the original claim submission before receiving a denial request?
I think if you have those processes in place right now, it can't hurt to add that documentation with uh, the original claim. But there are some payers that can bounce it out for just even adding that additional documentation as part of the claim. So you really want to be very in tune to what your payers are expecting. Some of them, again, that's something that you could have payer relations go to. You could have payer relations say, hey, every time we send you this CPT or this DRG or whatever it may be, you're denying it for an RFI or something else. Will you be okay with us, attaching this with the documentation so we don't have to, chase our tail every time? And you'll see either they're going to say yes or they're going to, probably you're going to see a mitigation in those denials themselves because you're doing the right thing. So that's a great thing to once you're able to identify those services, bring them to the table and say, this is a pattern we're seeing. Do we have to, how can we get this done on the first pass and have that at the negotiation table?
Thank you.
Yeah.
Um, Next one. Can you share some of the top CPTs and DRGs being denied?
Oh yeah, yeah, certainly. So I just have to stop screens. Let me go into our report. I can do this really quick. And this will be kind of a nice tease for folks that want to see what's in the guts of this report. But I know there's a section that has top DRGs being denied. I should know this off the top of my head. I've looked at this data a million times, but let me just find it. It'll take a second. I think it's page 12. Yeah. So we've got two different things in here. We have, and you'll get this, but I want to share it now. These are top 10 denied DRGs by the amount. So we wanted to show it by amount because this may not be the top five that are denied in general, but by amount because you want to be able to see what's being denied by the pure amount. So that's these right here, 018, 007, 014, and so on. But the top five that are denied most, regardless of that amount, and I don't think any of us are surprised with sepsis. We've got 291 for heart failure. We've got our deliveries, normal newborns, and 853 as well. So that's a really good view right there of what's being denied by charge amount or average denied amount, I'm sorry, and just purely one through, looks like one, two, top five being denied just by DRG. And we'll send this out, but we're also going to show you the top five CPTs by amount, as well as top frequently denied CPT codes as well within our community. And we'll break that down into E&Ms and procedures as well. So little sneak preview, but we'll make sure we get this out so everybody can see what's being top denied on both the facility and pro fee sides of the world. And again, these are great things you can go in and do pre-bill audits on, risk-based audits on, and so on, to really kind of not have to find the needle in the haystack, but use some of our data to really implement your programs. Um, so I want to thank everybody for coming. We made really good time. I know you're busy, but please get a copy of this report. Please reach out to us. Joy's also going to launch a survey right now that you can take, but again, feel free to reach out to us with any questions you may have. If you're looking for a software platform, we'd be happy to talk to you and not try to force it down your throat. We want to share our experience in the MDaudit community with you to really make your lives better, your work lives better on a daily basis. And again, fight that good fight. Thanks very much for joining, folks.